Welcome, and thank you for joining me today for the second of our three-part webinar series devoted to the biomechanics of patient handling and lifting. I'm Bob Williamson, a medical science liaison with Baxter's Worldwide Medical. My role is devoted to the engagement, evidence generation, and scientific exchange of information related to safe patient handling and movement. A principal goal is the reduction of harm to caregivers related to the lifting and moving of patients. Today, our focus will be on patient repositioning with the use of repositioning aids. Repositioning dependent patients in bed is the most common type of patient handling activity and is associated with high rates of injury to direct caregivers. In today's webinar, you will hear about research on the biomechanics of repositioning patients and how supportive aids aligned with specialized beds and surfaces can have a positive influence on injury reduction. Our presentation today will be led by my friend and colleague, Dr. Neal Wiggermann. Dr. Wiggermann is a senior research scientist. He leads the research and development in Baxter's dedicated ergonomics laboratory. Research and product testing to inform the design of Baxter's many medical devices. He is widely published and has been granted over 50 patents for his work. Additionally, he is a tireless warrior advocating for caregiver safety, specifically in the realm of reducing musculoskeletal injuries related to lifting and moving patients. He earned his PhD at the University of Michigan in Industrial and Operations Engineering with a focus on ergonomics. He also received his master's at the University of Cincinnati with a focus on occupational safety and health. And I'd be remiss in not adding that he is the president of the Association of Safe Patient Handling Professionals. Before I turn it over to Neal, I would like to offer a few reminders. This webinar is sponsored by Baxter and is a learning opportunity. The presentation content has been fully developed by the presenter. All lines during the presentation will be in silent mode. Questions can be sent at any time during the presentation via the Q&A box or by using the chat function. Any questions specific to Baxter products should be directed to our medical information team at medicalinformation@baxter.com. This webinar is being recorded for educational purposes, and the link to access the recording will be available shortly following the presentation. Just touching on our objectives. Today, we hope to accomplish discussing the guidelines for physical exposures to lifting, pushing, and pulling, effectiveness of repositioning aid at reducing the risk of injury, and under what conditions are aids appropriate. Just a couple last reminders. For our Q&A section, please type them into the Q&A box or using the chat function. Any questions, again, related to products can be dedicated to our medical information team. And again, one last reminder, we will be recording this, and for those that registered for the webinar today, they will have access to this particular recording. And finally, at the conclusion of today's presentation in our Q&A period, you'll see this screen, which allows you to complete an evaluation. Those evaluations help us establish it and define future presentations that you would find of value and interest as we move forward. Without further ado, I'd like to turn over this presentation to my friend, Neal Wiggermann. Dr. Wiggermann?
Hi, everybody. Thanks, Bob, for the introduction. As Bob said, first I want to point out, I'm an employee of Baxter. Baxter owns Hill-Rom and Lico. Bob also mentioned that I'm the president of ASPHP, the Association of Safe Patient Handling Professionals. I want to emphasize that this presentation is not affiliated with or endorsed by ASPHP. However, I hope that if you haven't heard of ASPHP or you might be interested, to please check them out. Their website is asphp.org. They have great benefits to members, including free webinars, a discussion group, an annual conference. The next one will take place in March in Atlanta, so please do check that out. So as Bob said, these are the objectives. I want to share research that can shed light on what type of repositioning aids are appropriate and when, but also I want to give some background on guidelines for physical exposures and predicting risk of injury. So love this topic. So thanks again for joining. So to start, it's important to talk about, why we're considering this. So if you were to rank all the occupations by annual musculoskeletal disorders, at the top of that list are people who move heavy things. Second on that list are nursing assistants. Then you have people who, are exposed to prolonged postures or working in warehouses. Then you have registered nurses. So, we have these outliers in healthcare, people that we should be leaning on for their brains and their skills, but, unfortunately are exposed to injuries. Most of those are caused by patient handling exposures. So, if you look at those injuries, those numbers are actually probably underestimating the cost of the problem. We ran a recent study and found that 80% of healthcare workers worked with their pain or injury that were injured. 43% missed work without making a claim, and 33% changed roles because of an injury. In the past 12 months, if you survey workers, 55% reported pain or injury in the back, 44% in the shoulder. And a similar statistic that 32% of nurses with back pain changed roles or are looking to change roles. So, there's a lot of hidden costs to these injuries too, and a lot of underestimates. So what's causing work-related musculoskeletal disorders? Intuitively, force. We know that high forces that healthcare workers are exposed to are causing this, but also posture. So it's really the force plus the posture that make the risk. Patients they're not like boxes that have convenient handles where we can hold in an ideal posture. We're exposed to lots of non-ideal postures. And then finally, repetition and a lack of ability to recover. A lot of nurses work 12-hour shifts. It's not quite the same exposure on an assembly line, but there are long hours and long shifts. And if we think about the relationship between posture and force, if you consider a situation here where we have a person lifting a box in two different postures, to hold this box, our back muscles have to contract, and that's basically squeezing the spine together. We also have a lot of complicated mechanisms in the shoulder that are creating a torque that resist the movement of the box and hold the box up. If that box is farther away from the body, the muscles in the back have to contract with more force, compressing the spine, and we also have more torque generated in the shoulder. So if we consider what's acceptable exposure to the tissue, and we have some research from decades ago that have led the scientific community to agree generally that 3,400 newtons of compression on the spine is where we start to have concern. Beyond that risk, we start to see beyond that limit, we start to see an increased risk of injury. And that comes from cadaver studies where researchers crunched cadaver spines. Also comes from epidemiological studies where we knew what exposures were occurring. There are also some guidelines for shear, 500 to 1,000 newtons. I'm going to focus, we modeled some of those in our studies, but I'm going to focus on compression because it has kind of the clearest line and is often the threshold that's exceeded before shear. So if we look at the shoulder, the other kind of high-risk site, you might be surprised to know that there's really no acceptable exposure to the tissue of the shoulder. There's no point where we say, oh, we think there's a shoulder injury. Part of that's because the shoulder is such a complicated joint. So how do we set limits to consider the shoulder? And so the answer is psychophysics. If you haven't heard of psychophysics, I promise I'll give a very brief overview. It sounds maybe like a new agey type of thing, but it's actually been a study for over 100 years. Psychophysics examines the relationship between physical stimuli and perceived sensation. So it's been used to detect a threshold of something or to determine a difference between something. Often that's been used for sound, touch, even taste. It's been used by the military to detect acceptable salt levels in military rations to find that threshold so it can be as salty as possible to preserve the food without offending the soldiers. But most importantly, in the 1960s, some researchers, Dover Snook and later Vincent Ciriello at Liberty Mutual Research Institute, and then some other researchers that joined them, started using psychophysics to determine what are acceptable exposures for ergonomics. And they did a series of experiments that are really wonderful over, again, many decades, where they brought in hundreds of workers and had them all day long push, pull, lift, carry, lower, do all these different tasks at different frequencies, heights, postures, and basically build these many tables that describe what is acceptable, quote unquote, acceptable to the workers. The workers would adjust those forces as they worked throughout the day. That might sound kind of squishy, but it turns out with epidemiological evidence, with epidemiological research, that these guidelines do seem to predict risk of injury when they're exceeded. And it sort of makes sense if you're working beyond what you really can do or what's acceptable in a day. You start to fatigue certain muscles, you start to adopt and change postures to unload those muscles and load potentially weaker muscles. Bad things happen that contribute to mechanisms for risk of injury. So if we go back to our acceptable exposures, we're working in the research that I'm going to describe, we're kind of working under this assumption of 3,400 newtons of compression being our limit for the spine. And if you consult the relevant portions of the table that would be closest to a lot of repositioning in bed, if you're looking at pushing and pulling, we accommodate 75% of females by staying under 57 pounds, and we accommodate 90% of females by staying under 49 pounds. So these again are the guidelines we're gonna try to keep in mind as we're looking at exposures. So with those guidelines, what can we say about when an injury will happen? Well, for a specific person at a specific time, we can't say a lot. These guidelines are really based on population data, and it's more like risk. So it's more like being at the casino and understanding when your risk is going to start to get higher. And in a lot of ways, it's like adding more double zeros at the roulette table as you move beyond these guidelines, especially for things like musculoskeletal disorders that can have cumulative exposures. So if we think about some of the mobility tasks, the patient handling tasks, as we go across the continuum of mobility, if we think about ambulation, there's not too much lifting there unless we're preventing the patient from falling, which is a whole other conversation and a whole other arc of research that we do need to talk about someday. But for this study, we're not super concerned. You're not going to be hopefully lifting a patient who's walking. For seated transfers, I sure hope you don't see much of this at your hospital. If we're transferring a patient, hopefully we're using slings. Now, the other thing that, again, is outside of the topic of this discussion is what happens when we don't have the slings. Well, the patient is probably staying in bed, and that's a harmful thing, and that's, again, another topic. Sit-to-stand transfers, this is something that Jake Banks presented in part 1 of this series. If you haven't seen that, I'd encourage you to check that out if it's of interest. But, Jake outlined the biomechanical exposures during those transfers and how we estimate that and what the risks are. But what we haven't touched on yet, and one of the big kind of concerns, is repositioning patients. So, this is one of the most common things that we do when moving patients, and some of the, maybe not as heavy of a load is moving and lifting a patient from a bed to a chair, but the frequency is a big part of the concern here. It's something we're doing a lot more. So there have been a lot of studies on repositioning patients. The limitation there, or the problem with applying those studies, is that a lot of them have found that we exceed injury thresholds for some of these activities. But the limitation with a lot of these studies is they often have considered one patient weight. They've maybe included one or two assistive devices at most. And they generally haven't looked at assistive features of the bed. So that kind of leaves us with the question, well, in a hospital, what should the guidance be for caregivers? When do we say, use this device on this patient, or this patient weight is okay under these circumstances? What is the big picture of what actions we need to take when repositioning patients, and what equipment do we need when? So we did a study a couple years back that set out to, to investigate this. And I'm also going to present results from other studies in context that might be new if some of you have seen this work before. So I want to describe the study somewhat briefly. We brought 10 caregivers into our lab. We have a motion capture lab. You can see we've got motion capture markers on that caregiver, and we'll talk about that more in a minute. These were caregivers who actually worked in healthcare. They had more than a year of experience regularly positioning patients. I think our average tenure was 7.5 years of experience. We also had 3 patients. These were healthy people who acted as patients. They were fully dependent. Mostly because that was a worst case scenario for patient repositioning, and also the most repeatable scenario from a research standpoint. So you can see their different weights. We're around 5th percentile patient, a little below a 50th percentile patient, and a little above a 95th percentile patient. I mentioned that we use motion capture. We were recording the force under the caregiver. We were also recording pull force, and I'll show how we recorded that in a slide here soon. We had 90 trials per subject. This was a pretty comprehensive battery of trials, so that we could test as many conditions as possible and compare them within our participants. We studied 4 different activities, so pulling up in bed or boosting, lateral transfers, lateral repositioning, which is something that often caregivers do without thinking about before they turn a patient. They might have to reposition a patient to make room. And then turning. And you can see here, this is turning a patient with turn assist in the bed. We also tested turning without turn assist, so the manual version. We looked at different repositioning aids. So we have a friction reducing sheet here. These were used as a pair. We tried to select particularly good performing repositioning sheets and also using them as a pair so we get maximum friction reduction. We're trying to say, hey, what's the best outcome we can get with friction reducing sheets here? We're going to give them the best kind of chance. These are handy sheets that LECO makes. We tested an air-assisted transfer device. So this is an AirPal that we happen to test. And this is a turn and positioning sheet. This is the Sage tap sheet. We had also a draw sheet as a control. We tested some bed conditions. I mentioned we tested turn assist, but I don't think I'm presenting those results here. We also tested trend Ellenberg. What if you use trend to help boost the patient up in bed, and max inflate of the surface. Our major outcomes, throwing back to what our concerns are for tissue loading. So we tested and modeled spine compression. So what is the load on the spine during these tasks? And then what are the hand forces for pushing and pulling? Getting back to kind of those psychophysical guidelines. And we had this structure built that connected to the sheets. You know, there's no perfect way to measure something without changing what you're measuring, but we did the best we could. This is just a few inches. This is a very small distance with a load cell. And instead of gripping the sheet, the caregiver gripped this bar, which created about the same hand posture and allowed us to measure what that pull force was. You can also see some reflective markers on here. This let us determine the direction of that pull force using the motion capture. So we feed that into a biomechanical model. If you're interested in biomechanics and biomechanical models, you should talk to Jake Banks, who presented in part 1, or at least check out his presentation. He goes into a lot more detail, but very briefly, and had a little bit of hiccups with these videos, so I'm not sure they'll work perfectly. But what we have here is an action in the lab. So this is a caregiver during one of our trials, boosting a patient up in bed. This is what we get from the motion capture. If it's not moving, please use your imagination. But these are the dots that are on that caregiver, those markers showing that movement. When we begin to model it, we start with a step where we load the we take those markers, and it informs them. It basically creates the movement of a customized skeleton that matches that caregiver. And then the final step is modeling the muscle forces. So determining what muscles, how muscles must be reacting to make that movement happen. And in general, we're considering the muscles in proportion to their strength and a recruitment pattern that would represent the way the body would work. From that movement and from all those internal forces in the body, that's how we determine and how we can estimate the loads in any joint, but particularly we're interested in the loads on the spine. And in this case, we modeled the L5-S1 joint, where a lot of back injuries occur, and it's also going to be force that's representative of the rest of the loading of the spine. So, sorry, it's a lot very fast, but I'm going to wade into some of the results here of our study. So if this is a lot to digest, so I'm going to stick here for a little bit. These are our estimates of spine compression. So this dotted line here at 3,400 newtons, this is the NIOSH recommended limit. And you can see here that we had some trials where, so these are the ranges of our trials. You can see there are trials where we exceeded that limit. We also had some means. These are the means of the trials that exceeded that limit. This is showing our outcome by the device tested. So the draw sheet plus Trendelenburg, the tap sheet, the friction reducing sheet, and then the air-assisted repositioning device. You can see that as for heavier patients, the load on the spine goes up. That's pretty intuitive. You can also see that the air-assisted device is reducing, significantly reducing this force. The friction reducing sheet definitely seems to be for the heaviest patient. I have to go back to our study to remember. We've run the statistics in our publication, but the friction reducing sheet did have significant reductions, and we saw significant reductions with Trendelenburg too. We did not test the draw sheet for our heaviest patient out of concern for injuring caregivers. We, in piloting, determined that to be pretty difficult. So in general, I mean, some good news. We're going over these limits some, but in a lot of cases we're below this limit for spine loading. Maybe that's kind of intuitive. We're not doing as much lifting as we would be for like a bed to chair transfer. The bed is taking some of the weight of the patient. Let's look at our other dependent variable though, the pull force. And in this case, you can see here we're exceeding those limits a lot more. So pull force seems to be more of a concern here. You see the same trends, the same patterns, which sort of makes sense. So as patient weight goes up, our pull forces are going up. We are seeing some benefit from the friction reducing sheet. The tap sheet seems to work not quite as well because we have, you know, it doesn't have as good of frictional properties, but it does have some friction reduction. You can see here. So these, if I just look at the 170-pound patient, you can see, okay, trend reduces it, and the tap sheet reduces it, and so does the friction reducing sheet, and so does the air assisted device, but it does seem to trend in line with their frictional properties. The air assisted device having the lowest friction and the draw sheet having the highest. So I'm going to put then these two charts right next to each other that we've just looked at, okay? And I'm lining them up. So I'm lining the 3,400 Newton line up with the 75th percent accommodation of female population here. And this is the 90th percent accommodation. And what you can see here is that, oh, sorry, I'm just seeing a question. The friction reducing, this is friction reducing sheets, and this was a pair of handy sheets in this example. So anyway, what you're seeing here is that the hand force seems to be more offensive in this case than the spine load. Spine loads still aren't trivial, but again, it's our hand force that's probably triggering our exceeding of the guidelines. And this sort of makes sense again because the bed's supporting a lot of the patient weight during these movements. We're getting the pull force that's more of a concern in these circumstances, which is kind of distinct from Jake's presentation and the bed to chair transfer study. So the two are kind of have some different mechanisms involved. So this is another chart that's I'm gonna pause here and take some time because it's complicated, but it's important because it's putting all of the results into a single takeaway chart. So it's worth your time to take a minute to process it, or at least I believe it is. So these are these numbers with the asterisk. These are the patient weights that we tested. This is the data that we have. And if the patient weight was below that threshold, we're calling it green. If the pull force was below that threshold for that patient weight, we're calling it green. If it was above the 90th percentile accommodation, we're calling it red. And if it was between that, let me go back. If it was between these lines here, we're calling it yellow, meaning we're kind of on that bubble. We're not accommodating 90% of females. We're accommodating 75%. So we're saying we're kind of in a gray area here. Wouldn't feel great about it, but anyway. So that's what this chart is showing. Now what we've done here is you can see we have a couple of lines here. We're just interpolating. So if we had a red here and a yellow here, we're taking we're assuming a linear line and finding that point at which the patient weight would cross that threshold. Kind of the same things you did in math long ago in high school. Not as complicated as the modeling that Jake talked about in the last presentation. So this gives you that sense. And if you see, forgive these numbers being not round numbers. This is because I converted this chart from kilograms. So if you go to our publication, you'll see this chart in kilograms. That's why these are not round numbers. But so for this example, let's say the friction reducing sheet, this would suggest that the friction reducing sheet, when a patient's around 200 pounds, we start to have some concern that we're starting to exceed thresholds of pull force. Whereas for the draw sheet, we're okay for this 110-pound patient, but at 170 pounds, we have exceeded the threshold. By interpolation, we expect to exceed that threshold around, I don't know, 145 pounds, say. Now, I'm going to add the other tasks that I didn't show you the results for because they're kind of similar, and I just didn't want to make you look at 15 different charts of lines that all look the same way. But if we load in those, if we load in these other tasks, so lateral repositioning, lateral transfers, and then turning with a draw sheet, you can see similar patterns. In fact, for pull-up in bed, the draw sheet, was okay for the lightest patients. But when we look at lateral repositioning and lateral transfers, the draw sheet, even for the lightest patients, exceeded those forces. The tap sheet and the friction reducing sheet, they again reduce the forces. They're getting us up to a little bit of a higher patient accommodation, but not still universally safe across that patient continuum. What you can note is that the air-assisted repositioning device, those things really reduce the force, and at least up to 311 pounds, we were below required for the guidelines. And then turning, we didn't exceed those guidelines. There are some publications that have shown some higher forces there. This is sort of a good news, though. It means that we can turn patients and potentially get repositioning sheets under them or other devices safely, so that we can then, for these high-risk tasks, have some mitigation. Although I would caution that, again, I mentioned that earlier, a lot of times when we turn patients, what do we do before we turn the patient? Well, we do this. So, a lot of caregivers might think of turning as not a difficult task, but, maybe as part of the host of what they're doing, it is. And then I've also heard anecdotally that sometimes turning might not be so bad, but holding the patient in place can also be a concern. So it's not a completely simple story there. Okay, for some context, I looked at the existing literature and reviewed, what have others done? And there are, again, a couple dozen studies on this topic, but not everything was comparable. Maybe they used different methods, or they didn't report. There were some studies that reported work by patient weight, but they didn't, well, they studied by patient weight, but they averaged everything together. So you couldn't see what the effect of the patient weight was or what the individual results were. But if you add some studies here, oh, I forgot my one animation. We have to point out, if you compare all these, if you look at all these risks, what you don't have a problem with is the overhead lift. It goes without saying that's kind of why we're highlighting these concerns, but need that there as a reminder. So if you look at other studies in this area, we have some consistency. I put where that study was for a given patient weight and if they exceeded guidelines. So here, we have red where we're red. We have a yellow where we're red. We have a green, and there's going to be a legend at the end for the references if you wanted to look at these papers. Here's a red where we had a yellow. So, in some cases, this study might suggest we're not sufficiently conservative here with the friction reducing sheet. And then others found the same thing. The one outlier here might be this one. This was a dissertation, but the researchers used a friction reducing sheet, and at about 150 pound patient weight, they did find exceeding the limits. So maybe just keep that in mind. It might be an outlier, I would think, but also, just remember, we are just one research team in one lab. And so, these are fairly consistent, but it's not the final story. One other thing to consider, my colleague pointed out, if you look for lateral transfer, if you look at the AORN guidelines, their guideline for, I believe the guideline for patient weight, at which point they recommend 4 caregivers and a repositioning aid be used, they recommend that, I believe, at 157 pounds. So, if a patient exceeds 157 pounds, AORN says use 4 caregivers and repositioning aids. This is pretty well in line with our findings as well. This is where these thresholds kind of start to hit. So I thought that was interesting. Okay, you don't get to talk to a researcher presenting research without listening to some limitations and considerations. So first part, the guidelines that we used, the psychophysics and even some of the spine loading, these were developed using younger, fitter working populations. So it's possible our research, our conclusions might not be conservative enough, especially if you have a population that is much older, much less well physically conditioned. Also, in those environments or that testing, it wasn't a stressful work environment. If you have caregivers that are under some psychosocial stress, which Jake mentioned in a previous publication, or doing some other alternative kind of work and postures and things that are different from those studies, you could have a slightly different result. Also, caregivers are using very dynamic forces, and some of those the research from those guidelines doesn't have as much of a dynamic force. So, there could be some variation in the applicability. As for the applicability, we tested 3 patients only, and they were standardized across all the studies. I think that was important for, being able to have consistency of results. But, we all know that not all 311-pound patients are the same. So somebody might have different body composition, different morphology that could affect results. You could use different models of repositioning aids. We tried to select representative ones that performed well. If you have one that's not performing as well, you might not get as good results, or just if it's a different functionality, you can get different results. We assume dependent patients. By all means, if you can get your patients to help, that might change things. That might shift that chart to your benefit a little bit more. It's also just a good idea for mobilizing your patients. It did talk about that AORN guidelines of adding more caregivers. Certainly, adding more caregivers likely does reduce the forces on the caregivers. However, it does not reduce the forces evenly. For 2 main reasons. One, we never get the timing right. Not everybody pulls at the exact same second on 1, 2, 3. And then, the other thing is that as you add more caregivers, one caregiver is standing closer to the center of mass of the patient than the others. So, somebody is going to be taking more. And so you get diminishing returns as you add more caregivers. Not something to ignore, but you get diminishing returns. We had, again, 2 caregivers in our boosting activity and our transfer activity. I think there's a lot of places in the hospital where if you're able to get 4 caregivers, you're very lucky. And then, finally, we allowed caregivers to set the height of the bed to what they thought would be comfortable, what they would do on their job. We tried to have them not do artificial circumstances. They performed the workflow, with the exception of needing to, hold on to our sensor as naturally as they normally would. But of course, workflow can be different for all caregivers. Okay, getting to applications here and takeaways. I kind of mentioned having the patient help. That's always great. Want to talk about things that are in the bed that you can use. So bringing the footboard in. We call it Flexifoot, on the Baxter beds, but most beds have some functionality that brings the footboard in. Bring it in, you can have the patient push against it. That can help with boosting. Definitely adjust the height. Height matters. It affects posture, which affects load on your tissues, on the body. We talked about Trendelenburg. That's a feature here. A lot of Baxter beds also have this boost function, which combines Trendelenburg and max inflate. We found in our study that that combination does give you a bit better result. We also have, here's max inflate. This is just an example of a bed control. Mentioned turn assist. Even if turning is a lower risk task, turn assist does help. That's very well published as well. So again, consider these things. Now, again, this is not going to make a situation safe for all patients, but it will shift that curve, and it might bring some of your lighter patients into an acceptable case. Okay, so last summary slide, I promise. But the big takeaway, these repositioning aids, it seems like they work. They do help reduce forces, but and so the manual repositioning with draw sheet, it was generally unacceptable for any size patient, with the exception of boosting a really light patient. Generally, the repositioning aids were unacceptable as you got above an average patient weight. And then Schrund-Ellenberg and Max and Flate, same story. They worked for average to below average. It was the air-assisted device and overhead lifts, that we know will provide the adequate risk of mitigation for all patients, or at least up to the 311 pounds we tested. If you were to kind of rank the tasks, again, it was this lateral repositioning and transfers. They were a little higher than boosting, and then far behind that was turning. Kind of mentioned, that the repositioning tasks probably have a different injury mechanism than standing transfers. So if you're getting lots of shoulder injuries, that could point you one direction versus back injuries. Of course, both types of injuries can happen for both types of tasks. And then, this we know, the gap between the guidelines and what's actually happening in the hospital is considerable. One more point on the air-assisted repositioning devices. When considering this versus overhead lifts, these are very different strategies. And so it depends on your circumstances. If you're going to pursue the air-assisted devices, make sure you've talked with your wound care teams and it's something that you can leave under a patient. Make sure you have access to the blowers and that, you're good with infection control and all that stuff too. At the same time, air-assisted devices can go in places where you can't get a patient lift necessarily. If you're a first responder, that definitely gives some good evidence for that, where other things might not be appropriate. So that's the end of this talk. Please, there's one more talk in this series, and it's going to be presented by Kelly Clapper. She is a clinician at Nebraska Medical Center, and she's going to be talking about applying a lot of the research that Jake and I have talked about regarding a lot of our lab work. It's going to go into the field with Kelly here. This is our publication that we referenced. It's open access, so it'd be free for you to download. And I think from there, here's some references. These link back to our that figure. And from there, I think would love some questions. So thanks for making it through a presentation about repositioning patients and biomechanical analysis.